Okay, well today we're going to be talking about anxiety and obsessive-compulsive disorders in children and adolescents. And so a lot of this is going to be familiar and a bit of review from what you have already covered in abnormal psychology and Psych 2285 when you covered anxiety disorders. But we're going to talk about how the disorders may be different in children, and also a couple of the disorders that we're more likely to see in children that we're not as likely to see in adults. But before we get too far into it, I want to start with just making sure we're all on the same page, doing some description and definitions just to make sure we're all rolling. And we'll cover this pretty quickly. So when we're talking about anxiety, we're talking about a mood state that is characterized by strong negative emotion and bodily symptoms of tension in which the child apprehensively anticipates future danger or misfortune. And so there's an element of fear here. And so one of the things that we have to remember with anxiety is there's this anticipation part. We often call it anticipatory anxiety, but they're worried about something that's going to happen. But there is also the strong negative emotion, right? So we experience emotion, and we can experience strong negative emotion about lots of different things. It's not anxiety unless there's that element of like what we're worried about happening. Okay, and when we're talking about anxiety disorders, these are diagnosed when a child experiences excessive and debilitating anxieties. So one of the things that you want to remember, and I'm going to actually get to this in the next slide a little bit, is that we all experience anxiety from time to time. That's true of children, that's true of adolescents. It's even true of infants, right? We see infants get anxious when a caregiver disappears from view or when their favorite toy rolls out of view. So we know that everybody experiences anxiety from time to time. That does not mean everybody has an anxiety disorder. When we're talking about a disorder, remember the distress, the impairment, and it becomes, especially in children, we see this excessive and debilitating anxiety. It's normal for children to not want to be separated from their parents, particularly things like starting school, right? A lot of kids have a hard time when they first start school. They cry, they fuss, don't leave, they grab onto their parent's leg. When parents go out for the evening, or when once upon a time people could actually go out for the evening, of course these days not happening that much, and a child says, no, don't go, I want you to stay. That's normal. But we're going to see later on today some examples of when that goes to the excessive and debilitating anxiety. Particularly when we talk about separation anxiety disorder. So when we are experiencing anxiety, we have that activation of our fight or flight system. And again, remember, when our fight or flight system gets activated, we're like, oh no, danger, what do we do? Do we run away or do we fight it? And what happens when fight or flight gets activated is we see it happening in three different places. We see the physical system, the cognitive system, and the behavioral system. So from the physical system point of view, it's the activation of the sympathetic nervous system, so that actual fight or flight response, and we have those somatic changes. So remember, fight or flight, we are suddenly looking like we want to take in every bit of information around us. Our heart's beating a little bit faster, we might start sweating, our digestion shuts down because we have to make sure we can have all the energy we need going to our muscles so that we can run away or fight, right? So that's the physical side. The cognitive side is we immediately start searching for the threat or the danger, right? So it's like, okay, what is this thing that's causing me to have these physical symptoms, right? What's this thing that is scary and that is potentially dangerous? And then for the behavioral system, we start looking at things like avoidance behaviors. So a child might fake being sick to get out of doing something that's especially anxiety provoking. Or we see that hyperarousal, so that fidgeting, that like foot tapping or pen tapping, right? That just inability to sit still, that hyperarousal, hyper-awareness of everything, looking around a lot. So that's what happens when we activate fight or flight. And as adults, you know how uncomfortable that could be, but you also are able to hopefully sometimes tell yourself, okay, it's just an exam, right? So think about exam situations when you used to come to campus and actually write them, especially if you ever had to write them in the gym and there's all these people at these desks in rows and you can feel that nervous energy in the room, and you start looking around, and maybe you're fidgeting with your foot, and you're like, I'm sweaty, like it's really hot in here, right? And then you tell yourself, relax. It's an exam. It doesn't determine my future. It doesn't determine my worth. Even if I fail, I'm still a good person, right? So you're able to calm down, and then also remember things like, oh, I went to class. Oh, I studied. Oh, I did the readings. I got this, right? So we're able to do that. Children aren't always as able to do that because they aren't aware of what is triggering them. They're not aware of what they can do to calm themselves back down. One of the other things we need to do is we do need to make sure that we discriminate between anxiety and panic and fear. So again, all oftentimes in everyday language used as interrelated terms, but actually a little bit different when we're thinking about it from the perspective of anxiety disorders. So fear is an immediate alarm reaction to current danger or life-threatening emergencies, okay? Fear is very much present-oriented. So as I'm standing here in this room, if all of a sudden the fire alarm went off, I'd have a fear response, right? Because it's like, usually at MRU, if it's a fire drill, we get a notification ahead of time. We know that it's just a drill. I have seen no such notification, so here I am, I'm on campus, I'm focused on what I'm doing, I hear the fire alarm, and actually right in my line of view is the emergency exit plan, so I'm like, okay, let's do this thing. That's a fear reaction. Panic is a group of physical symptoms of the fight or flight response that unexpectedly occur in the absence of any obvious threat or danger. So one of the things that we know about panic attacks is they pretty much crop up out of nowhere. When you have a panic attack in response to a specific cue, that would not be the type of panic that gets classified as panic disorder. Panic disorder are panic attacks that happen unrelated to anything going on. And so panic is we have that fight or flight response, but we don't know why. There is no threat or danger present. So as I'm standing here, this is now is it the third or the fourth day that we're filming? Fourth. It's the fourth day that we're filming, so by now I'm pretty comfortable in this space. I know the lay of the land, I know what's going on. It would be weird if all of a sudden my heart started beating really rapidly and I was having trouble breathing and my muscles all tensed up and I was like, oh my God, what am I doing here? Like what? That could be panic, right? So unexpected. Whereas the first day coming in, I didn't really know what to expect. I didn't know what the room was gonna look like. I didn't know how many times I was gonna step over my imaginary, well, not imaginary, my very real bright yellow line. Because if I do that, oops, I'm out of frame. So I have to make sure that, oh, quasi, okay, I gotta step further. If I go here, then I'm out of frame, right? So now I know the room, I know what to expect, I know how this is gonna go down. There's no reason for me to even be nervous about it. And in fact, I really wasn't. But the first day, yeah, I was pretty jazzed up, okay? And what we want to remember again, sorry, I'm going to actually back up for a sec. I would do this in class too, where I'd go forward a point and then I'm like, oh, right, I forgot to say. So the other thing to keep in mind is that anxiety is future-oriented. So we're worried about something that may happen. So fear is that immediate alarm reaction. It's present focus. There is something going on right this moment that is really, really terrifying, frightening, scary, unexpected. Panic is we have those physical symptoms and we don't know why. Anxiety, we have that activation of fight or flight, so we have those physical symptoms, but we know why. We're worried about something that's going to happen in the future. Now, I already sort of alluded to this at the very beginning, that normal fears, anxieties, worries, and rituals. This idea that all children have these. Okay, all children are scared of things. All children, maybe not all children, most children have rituals. They like things done in a certain way. And so what we have to look at is how old is the child to determine if it's age appropriate, and that's where we would also take developmental disabilities and cognitive delays into account. we have to look at what's happening in the child's world. A child growing up in a country that's at war is going to realistically have more anxieties, fears, and worries because their life is actually threatened on a regular basis, as opposed to a child growing up safely in Canada in secure housing with a steady food source, education, clothing, and all that, right? So we have to consider age, we have to consider context, and we have to look a little bit at the impact as well that it could have on the child. So there's a lot of things that we consider here, and this is normally a place where I would say, like, okay, why don't we identify some of those normal fears, anxieties, and worries and rituals of childhood? So let's keep this in mind, that when we meet for discussion, that might be something that we can talk about. I'll give you just a couple of examples right now. A lot of children are scared of the dark, right? A lot of children, their room gets really dark at night, they're scared. They might want to have a night light or a lamp. I can remember as a younger child, I always wanted my parents to leave the light in the hallway outside my bedroom door open, and my bedroom door just cracked open a little bit. So my room was mostly dark, but if I opened my eyes or if I got scared, I saw a little bit of light from the hallway, and that for me was enough. Some children will sleep literally with their lights fully on because they're too scared of what there might be in the dark. When you hear, as a child, you hear a strange noise, sometimes they get worried about that. So there are definitely things that are normal fears and worries, monsters under the bed, boogeyman in the closet, you know, Donald Trump winning the election. Oh, that's more of an adult fear, but that is a real fear at this moment in time. So yeah, we'll move on from there. Okay, so the anxiety disorders according to DSM-5, and this is where I just have to sort of do a quick check. There are 7 diagnoses. Okay, I do not have them coming up on a slide. I'm never sure, but if you look at page 360 of your textbook, you will see just kidding, it was page 360. It's actually page 363 of the 7th edition, so it's page 360 of the 6th edition. You will see the main features of the 7 DSM-5 anxiety disorders. We're going to go through all these disorders as we go on with the lecture. They are separation anxiety disorder, specific phobia, social phobia or social anxiety disorder, selective mutism, panic disorder, agoraphobia, and generalized anxiety disorder. And here we are with reflection question number 1. How are anxiety and stress different? So take a moment and think about it. And if you're thinking, Carrie, you haven't really talked about stress yet, correct. But you've heard about stress in other courses. You've maybe even read about it in the textbook. We've reflected. We're coming back. We're ready to talk about separation anxiety disorder. In separation anxiety disorder, children display age-inappropriate, excessive, and disabling distress related to separation from parents or caregivers and a fear of being alone. Okay, so age-inappropriate, excessive, disabling distress related to separation from parents or caregivers and a fear of being alone. So I was saying earlier that it's normal for most children, especially when starting something new, going to school, or parents going out for the evening, to say, no, don't go, I want you to stay, blah, blah, blah. And typically, as soon as their attention shifts, they're okay. They recommend, I know when our daughter started daycare, they recommended, having a set goodbye ritual, so not hanging around for too long and basically preparing our child for, we're going to drop you off, we're going to give you a hug, give you a kiss, walk away. And that's it. And then the kids are comforted by the routine and they're okay. They may be upset at first as they warm up, get used to the environment. They typically settle back down. Children with separation anxiety disorder do not settle back down. They take it to the extreme. And I'm going to share an example. When I was in high school, I used to babysit the children of my parents' friends. And it was a really interesting situation. They had a boy and a girl. The boy was older, the girl was younger. And the boy had fairly intense separation anxiety disorder. And so even though he had pretty much known me his whole life because our parents had been friends that whole time, my brother had babysat for them before me. So again, they were familiar with our family, familiar with, with us. We sometimes got together as families, but sometimes, I showed up to babysit. And this boy would just be in like a tizzy. And it was always his fear was about something happening to his mom, not his dad. It was like dad could go, but mom, that was a problem. And and this was pre-cell phones, so mom always had to call like halfway through whatever activity. So if they were at a play at the intermission, if they were out for dinner, like just before the main course arrived, she always had to call to check in. He also used to ask, like, call when you get there, let me know that you're there. And anytime he heard a siren throughout the evening, he would go into a panic thinking, that's an ambulance, or that's a fire truck, or that's a police car going to my mother because they were in an accident, or she got sick, or something happened. And it was like nearly impossible to reassure him. He would get really worked up. And I remember one time even his younger sister just looked at him and said, relax, mom's fine, go to bed. She was fine. It's like bedtime. She's like, okay, good night. He never fell asleep until his parents came home. And they knew this. He would go to bed. And then if he heard a siren, he would pop out of bed and be like, oh my God. And otherwise, he would just lie there, but stay awake. He never could fall asleep until his mother was back in the house. And then pretty much the minute she walked in the house, he could fall asleep and he was fine. That's fairly extreme. She also, when he started school, she was at kindergarten with him for the first couple of weeks, I think. Slowly working her way out the door. So that is what we're talking about when we're talking about separation anxiety disorder, a far more extreme reaction, debilitating, and causes the child a lot of worry and anxiety. You'll find the diagnostic criteria, table 11.3, page 363 in the 6th edition, page 364 in the 7th edition. Okay, so you'll go ahead and want to take a look at that. And then I just have a brief video here for you to watch. It's only about 3 minutes, but it just gives you a sense of what separation anxiety can look like. So take a look at that, and then when you're done, come on back, and we will talk about school reluctance and refusal. So school refusal behavior is when a child exhibits refusal to attend classes or difficulty remaining in school for an entire day. One of the things that we want to be clear about is whether it is actually separation anxiety disorder or is it only related to school. If it's only related to school, if they're fine being apart from mom, dad, caregiver, whoever it is, to go to their grandparents' house or to go to a friend's house to play or whatever, parents go out for the evening and there's a babysitter, then it's not separation anxiety disorder. Then it's school reluctance and refusal. So that's something we're going to look at differently. We're not going to look at it as anxiety. We're going to look at what's going on at school. And that's when typically when we see someone with school reluctance and refusal, we're going to want to do things like assess for learning disabilities, assess for ADHD, assess for phobias, like is there something that they're really deeply afraid of that is present in the classroom? Sometimes schools have a class pet, and some kids are afraid of hamsters. I mean, they're rodents. So, you're afraid of mice, you're afraid of rats, you extend that to hamsters, you don't want to go to school because there's a hamster in your classroom. Well, let's deal with the phobia, and then the school refusal behavior can go away. Okay? So oftentimes, school refusal will happen also after kids have been home for a long time with their parents. So I know there was some concern heading into this fall after children were home since March oftentimes with their parents, sometimes another caregiver, but schools had closed in March, that kids going back in September would really struggle with that, and some kids may in fact refuse to go because now they've been home for so long, they no longer want to go. Okay, already sort of mentioned with the fear of hamsters, this idea of a specific phobia, so let's go there next. A specific phobia is a persistent fear that is irrational or exaggerated, leads to avoidance of the object or event, and causes impairments in usual routines. So really, nothing different than specific phobia for adults here. The important thing here to remember is that the fear is inappropriate for the child's age. So I mentioned earlier that it's normal for children to have some fears. It's normal for children to have some worries. Things like a fear of the dark, fear of monsters under the bed. Those are pretty normal childhood fears, but we eventually expect them to go away. So a 5 or a 6 or a 7-year-old who still sleeps with a nightlight or insists on having a light on in the bathroom or in the hallway so that there is light if they wake up in the middle of the night, like that's normal. We're okay with that. A 17-year-old who still sleeps with a nightlight. We're heading into less okay land there, right? So we have to think about, this is where really thinking about how old the child is, what their circumstances. Again, we have to take into account any cognitive or developmental delays, also any past experiences. So a child who, let's say, came to Canada as a refugee from Syria, they may have a fear of the dark a little bit longer because they are coming from a much different perspective. And it might actually be related to PTSD more so than a specific phobia. So again, context is always going to be really important, particularly with phobias. And phobias are more than just dislikes, right? So there's a lot of things that children don't like. There's a lot of things that children are reluctant to do. Perfect example, at this time that we're filming, this may not be true of when you watch this, it's flu shot season time. And I can tell you, my 5-year-old was not all that excited about that. When I picked her up from school last week and said, hey, we're going to get flu shots today, it was not met with excitement. Everybody in Shoppers knew that my child did not want to be getting her flu shot that day. She made that pretty clear. But she did it, and then she was fine, right? So she does not have a phobia. She doesn't like getting a shot, and I understand that. But again, you got to do what you got to do. So PSA, get your flu shot, especially this year. The diagnostic criteria for specific phobia, table 11.4, page 366 in the 6th edition, page 367 in the 7th edition. And here we are to reflection question number 2. If a child has an age-appropriate fear that causes distress and impairment, are they diagnosed with a specific phobia? So this you got to really think about here for a minute. If it's an age-appropriate fear, but it does cause distress and impairment, is it a specific phobia? Coming on back. And so yes, we will talk about that, by the way, in discussion, but I'm really curious to see what your thoughts are. Social anxiety disorder, which is also sometimes known as social phobia, is a marked and persistent fear of social or performance requirements that expose them to scrutiny and possible embarrassment. And again, you'll find the diagnostic criteria, table 11.5, page 368 of the 6th edition, page 369 of the 7th edition. But so this is really, it is a phobia, but it's a little different because it's not a specific object like a specific phobia, but it's this social anxiety, right? We call it social phobia or social anxiety disorder. And if people are in a situation where they feel like they're going to be judged, mocked, made fun of, embarrassed, that gives them tremendous anxiety. And so, again, to differentiate between sort of normal and maybe social anxiety disorder. I know that the vast majority of you watching this right now were probably quite relieved when we shifted to online because it became, I'm not going to have to do an oral presentation in class. Or perhaps when you read the course outline and saw there was no oral presentation. What I have learned over my years of teaching is that students, by and large, hate oral presentations. Of course, as an educator, I know that there's value in them. I know that there's value in being able to articulate your thoughts, concisely and speak them and be able to present to other people, which is why I often put oral presentations into my 3rd and 4th year classes. But universally, I know students hate them. That's not necessarily social anxiety disorder. That's, I don't like standing up in front of a group of people and talking. Okay. A person with social anxiety disorder might feel the same way, but they would much prefer a scheduled oral presentation with parameters that they know they can practice than an informal class discussion where they are expected to participate and to contribute and say something that other people haven't said, because they can't prepare. And what if they say the wrong thing? Or what if they say something that is perceived as stupid by other people? Or what if they get tongue-tied, right? An oral presentation that you can practice, that you can memorize, that you can rehearse, and that you could basically feel like you could recite it in your sleep is going to be less anxiety-provoking for somebody with social anxiety disorder than a discussion. Formal things are way better than informal things, right? So the stereotypical cocktail party where you're expected to mix and mingle and chat with a bunch of people, holy, that is awful for someone with social anxiety disorder. So when you think about children, and you think about some of the situations we put them in, so sometimes, and you guys all know this because I remember how relieved you were on the first day of class when I said, we're not going to do any sort of icebreaker or anything. You're just going to say your name and we'll move on. Icebreakers are something that we do to kids a lot, right? Sports activities, school, camps. And for a child with social anxiety disorder, that's terrifying because they don't necessarily know what's happening and they don't know whether they have to pick a breakfast cereal that starts with the same letter as the first letter of their first name, or a flower that like there's a gazillion different things that we can choose, and it's like, oh. So that's social anxiety disorder. Informal situations where the expectations are unclear and where there's high evaluative components are incredibly stressful and distressing for people with social anxiety disorder. Okay, so I have the note in here, but I don't have it here. There's an article that you're going to find on Blackboard. It is called Loneliness and Shyness in Adolescent Problematic Internet Users, the Role of Social Anxiety. And so please make sure that you have read this because we will discuss it in discussion groups. So again, it is the last article on the article list on Blackboard, Loneliness and Shyness in Adolescent Problematic Internet Users, the Role of Social Anxiety. And I just think it's an interesting concept for us to talk about, especially thinking about how social anxiety could manifest differently as we shift to more of an online environment. And of course, this was published in 2014, so this is very much pre-pandemic. I'd be really curious to see what you guys think about what things might look like today when we have shifted much more to an online environment for learning for adolescents, for learning for adults, but also for social opportunities. Okay, so now on to selective mutism. Selective mutism used to be in the category of diagnoses that are typically first diagnosed in infancy, childhood, adolescence in DSM-4-TR. It was moved over to the anxiety disorders for DSM-5 because it's thought that anxiety is what's underlying the mutism. And this is when children fail to speak in specific social situations in which there is an expectation to speak. So we expect children to speak in class when they're asked a question, right? We expect them to speak when they're playing with their friends. And we will have some children who, at home, chat with people they're comfortable with, chat, but put them into a situation that's unfamiliar or uncomfortable, and they just flat out refuse to speak. And this is going to be a tricky one to diagnose. First of all, it's probably be a little while before somebody, actually a parent or a teacher, sought some help. And we have to also then discriminate between children who are, as we know, a little bit slower to warm, a little bit more shy, who may speak, but may speak very quietly, or they may whisper their answer to a parent to then say the answer out loud for them. They may prefer to write their answer than to speak. So it's not that these are children who lack the ability to speak. It's not that these are children who lack the ability to put their thoughts into words. It's that they are so anxious in specific social situations that they just will not speak. Okay? Fairly rare. Okay, so this now takes us into panic disorder and agoraphobia. This also takes me to needing a sip of coffee. So we talked already a little bit about panic today. And so panic disorder is diagnosed when there are recurrent unexpected panic attacks followed by at least 1 month of worry about having another attack. So there's a couple of things at play here that we need to think about. Number one, the panic attack is unexpected. So I had said earlier that if we have a panic attack in response to a specific cue, then it's not going to be panic disorder. But the other important piece here is that it's followed by at least 1 month of worry about having another attack. Some people will have unexpected panic attacks and be able to tell themselves, okay, it's just a panic attack. Not sure why it happened, but it is what it is. And they don't worry about having another one. They would not be diagnosed with panic disorder. They may have several panic attacks, but if they're not worried about having more, it's not panic disorder. If it's recurrent unexpected panic attacks followed by at least a month of worry, then we start looking at the diagnosis for panic disorder. When we're talking about a panic attack specifically, we're talking about sudden and overwhelming period of intense fear or discomfort that's accompanied by 4 or more physical and cognitive symptoms characteristic of the fight or flight response. So again, here's that fight or flight response coming up. A panic attack is essentially the activation of the fight or flight response, and we don't know why, right? So if you're someone who has been in a car accident and you are now driving for the first time since your accident, and you see a car coming up way too fast behind you, and you have a panic attack because you are worried they're going to hit you, that's not unexpected, right? We would almost expect that. So that wouldn't classify. If, on the other hand, you've never been in a car accident, you've never gotten a speeding ticket, you've never had any trouble with driving whatsoever, and you're driving down Deerfoot one day, it's not even traffic, and all of a sudden you start having a panic attack, ooh, that could be panic disorder, right? So again, there's nothing that's cueing it, there's nothing that's triggering it, there's nothing that suggests you should be having it at that moment, and you are now having these fight or flight reactions both cognitively and physically. You'll find the diagnostic criteria on page 372 of the 6th edition, page 373 of the 7th edition. Okay, and agoraphobia is something that is also related to panic disorder, because what ends up happening is people will develop marked fear or anxiety in certain places or situations. Oftentimes, it's that they've had a panic attack somewhere. So oftentimes people have panic disorder with agoraphobia or panic disorder without agoraphobia. So oftentimes with agoraphobia, they've had a panic attack in a particular place, and now they're worried about having a panic attack in that place again, so they then start avoiding that place. In severe cases of agoraphobia, the child or adolescent will be housebound. They will not leave their home. So imagining, if you will, a child who has switched schools at grade 3 because their family moved. They now go to this new school, and on the first day of school, they have a panic attack in the classroom. And they've never had a panic attack before, and they are deeply, deeply embarrassed by having had this panic attack. They didn't know what was happening. They started crying. Maybe they even wet their pants, right? Which in grade 3, we're already not really at that stage anymore. So hugely embarrassed. And then they're like, I can't go back to school. And parents are like, well, you have to. And they're like, no, you have to move me to a different school. Like, I can't do this. I can't face those people again. And parents are like, no, you have to go, you have to go. And they force their child to go, because that's what you really should do anyway. And the child basically spends all day, every day worrying, what if I have another panic attack? What if I have another panic attack? What if I have another panic attack? And lo and behold, they have another panic attack one day, and they're like, that's it, I can't do this, I can't go to school. And so maybe the parents are like, okay, let's talk to your principal about seeing if we could switch your class, right? Maybe they can switch the class, maybe there is another school, maybe there isn't. So eventually the child may just retreat and be like, no, you gotta homeschool me, I'm not leaving the house anymore. That's agoraphobia. And you will find the diagnostic criteria for agoraphobia on page 373 or 374 of the new edition. And so again, this is going to be pretty extreme. Agoraphobia definitely gets our attention, and it also can be very, very challenging to treat. Moving on to generalized anxiety disorder. Okay. When we're talking about generalized anxiety disorder, we're talking about excessive and uncontrollable anxiety and worry about many events or activities on most days. So generalized anxiety disorder is another one that can be very challenging to diagnose because it's just basically an extreme version of everyday worry. And so a lot of us have stuff that we worry about on a daily basis. A lot of us have things that we're, okay, don't forget to do this, and what happens if this happens, and oh my gosh, I forgot to do this assignment. What does that mean for for my grade in the class, for my future, for graduate school? We all have those thoughts from time to time. This is excessive and uncontrollable. This is that the child is worrying even when they're doing something that should be absorbing their attention and would give them no reason to worry. People often develop somatic symptoms, so oftentimes muscle tension, stomach aches, headaches will happen as a result of generalized anxiety disorder. So it's more difficulty sleeping for sure. And again, difficulty sleeping can happen with regular worry. Headaches and muscle tension and stomach aches can happen with regular worry. But this is happening to the extreme. This is most of the time the child or the adolescent is worried about things and they cannot control that worry at all. You'll find the diagnostic criteria, table 11.8, page 375 in the 6th edition, page 377 in the 6th edition. Now, we're also going to talk a little bit about obsessive-compulsive and related disorders. And so in DSM-4-TR, obsessive-compulsive disorder was considered an anxiety disorder. In DSM-5, they have a new chapter for obsessive-compulsive and related disorders. And so we do still believe there's an anxiety mechanism at play with obsessive-compulsive and the related disorders. But we also recognize that there might be some other stuff going on. A lot of the disorders that fall into obsessive-compulsive and related have like an impulse-driven aspect as well that we don't necessarily see in the anxiety disorders. So when we're talking about obsessive-compulsive disorder itself, it's recurrent, time-consuming, and disturbing obsessions and compulsions. And of course, when we're talking about obsessions, these are the persistent and intrusive thoughts, urges, or images that are experienced as intrusive and unwanted. And the compulsions are the repetitive, purposeful, and intentional behaviors or mental acts that are performed in response to obsessions in an attempt to neutralize or suppress them. So I'm going to give you a second to absorb that while I absorb a little more caffeine. And then come back. So again, you've heard about OCD before, you've heard about it in other classes. We know that the obsessions are the thoughts, the compulsions are the actions. So the thought is there are germs everywhere. I need to make sure I don't get sick. I don't want to be contaminated. The compulsion is the repetitive hand washing. In some ways, the current COVID-19 pandemic has really played into people with OCD who have fears of illness and germs, because everybody's supposed to be washing their hands all the time or using hand sanitizer when they can't. They're like, see, I'm normal now. Because everybody, but it's still not, because they're still thinking about it. It's that the compulsion is to get rid of the obsessive thought, right? And of course, it doesn't work for very long. So then they have the thought again, then they have to go hand wash again. There are people who believe in sort of superstitious rituals to try to get rid of the obsessive thought. And so they have to turn light switches on a certain number of times when they come into a room or leave a room. They have to lock the door a certain number of times. So it can be very disruptive, and it's very intrusive on the person's life. And so again, you'll find the diagnostic criteria, table 11.9, page 378 in the 6th edition. I think that's the right edition number. Yes, this is the 7th. Just double checking. And page 380 in the 7th edition. Okay. The related disorders. So this is the new part to DSM-5, that we now have the related disorders to obsessive-compulsive disorder. Again, these disorders always existed. They were just in other places of the DSM. So we have body dysmorphic disorder. We're not as likely to see that in children. We'd be more likely to see it in adolescents, where here is where they believe that some part of their body is just wrong, to put it mildly. So I can remember a young adult, so it was a university student, who came to see me for counseling, and he really believed that his nose was too big for his face, and it really bothered him, and it was all he could think about, and every time he passed a mirror or a window, he was like, oh my God, this nose, and I looked at him and I said, like, objectively, like, it's okay. Like, it's not that bad. His solution was not to continue with counseling to try to change his perceptions about his nose. His solution was to book plastic surgery for Christmas break, and he got a nose job, and boom, he was okay. So oftentimes that is what happens with body dysmorphic disorder, that people will seek out cosmetic surgery in order to alter the part of their body that they find does not match them. The problem is that doesn't always make it go away. Sometimes they then will fixate on a different body part. But again, looking at the person objectively, and in his case, I'll be honest, like, was his nose maybe a little large, maybe a touch, but like not outside of normal limits, right? So again, we think about what's sort of normal, but that was how he chose to solve the problem. Another related disorder is hoarding disorder. So people who hang on to stuff, and stuff that they particularly don't need. And a hoarding disorder, of course, we see extreme examples on TV on the show Hoarders. I mean, they just made it pretty blatant there. Obviously, if we have a child who can't navigate out of their bedroom because they have too much stuff in there, we have problems on multiple levels. But we might see it with children with things that start out innocently enough, like, you know, they go on a beach vacation and they collect a few seashells, but next thing you know, like, their room is all buckets of seashells. We might be a little too much, right? So again, probably not as likely to see hoarding disorder in children and adolescents. We're more likely to see that in adults. Another one, though, that we might see in children and adolescents is my favorite disorder to say, trichotillomania, and that's hair pulling. And so that often starts, people will often start sort of at the back of their hairline, so where it's not very obvious. It's a bit of a nervous habit. They're playing with their hair, they yank it out. And apparently that feels good. Not to me, but for people with trichotillomania, there's some anxiety relief that comes from that. As they continue doing it, they will sometimes develop bald spots. And people will also sometimes move on from the hair on their head to eyebrows, eyelashes, any body hair, even pubic hair. So going at it with tweezers, obviously not in children, but in adolescents that could happen as well. And then we also have excoriation disorder. And excoriation disorder is skin picking, basically. So poor Ian is like, oh, why am I paying attention all of a sudden? Like, I should go back to doing something else. So where people pick at their skin, and again, it's a nervous habit, right? It's an impulsive thing, but it can lead to infections, it can lead to bleeding, and just, it's not the most pleasant thing. But it is an obsessive-compulsive related disorder. Okay, some of the associated characteristics with obsessive-compulsive and related disorders. We do see some cognitive disturbances. So in terms of intelligence and academic achievement, we typically see normal intelligence, so IQ scores that are well within the normal range, but we will sometimes see lower academic achievement because of the anxiety, right? And so this is actually associated characteristics for all, no, just for obsessive-compulsive. I don't even know what I'm saying anymore, guys, sorry. For the obsessive-compulsive. So lower achievement because there's so much anxiety and so much time being spent on the obsessions and the compulsions. We also see for people with anxiety disorders in general as well, threat-related attentional biases, which is that people are pretty hypervigilant and they don't learn that some potential threats aren't actually dangers, right? So they see something, they see things that are clearly not threats, but they interpret it as a danger, and so that makes them anxious. So for example, there is one of these like rubber covers here over the cables. Now, normally in a classroom situation, you would see me trip over that at least 3 times a class, okay? Because in a normal classroom situation where there isn't a video camera on me, I'm walking all around, right? And so I'm walking over here, I'm walking over there, and whoops, I'm tripping all the time. If you've had me for class before, you know that. Particularly, I can remember in my sports psych class one year, I bumped into the screen so much that a student took part of a pool noodle, put caution tape on it, and put it on the screen to try to protect me from that. Now, I'm the type of person who doesn't perceive these things as threats, right? I trip in class, I bang into things in class, I say the wrong thing in class more often than I probably should. I make mistakes, I make spelling errors. None of that is a threat to me. I feel pretty good about what I'm doing, that I can live with that. There are other people who would look at this rubber covering the cables and be like, oh my God, that's there to trip me on purpose. That's there to make me look like a jerk, right? Someone with social anxiety disorder would be like, that's there to set me up for embarrassment, that I'm gonna kick it, I'm gonna step on it, or somehow I'm gonna end up pulling all the cables out of the wall. And it's like, no, it's actually just there so you don't get tangled up in the cables and step on them, okay? So threat-related attentional biases, also things like, and this isn't happening right now, but sometimes there's like a fly in the classroom. And I'd be like, ooh, there's a fly. Someone else might be like, oh my gosh, well, what if it's not a fly? What if it's a wasp? What if it's a mosquito? What if it's gonna come sting me? Do I have my EpiPen? What if I'm allergic? I don't know if I'm allergic. And so then all they can think about is this fly and how they have to stay away from this fly because this fly could actually be like, what if it's carrying West Nile disease? What if it's gonna give them Zika? What if their brain is gonna suddenly start to shrink, right? They're paying attention to something and interpreting it as a threat when really it's a fly. It's benign. We also see cognitive errors and biases, perceptions of threats that activate danger-confirming thoughts. So again, misperceiving things and then interpreting it as threatening. Physical symptoms, we see headaches, stomach aches, sleep problems, social and emotional deficits, shyness, being withdrawn, difficulty with peers, right? If you're really anxious, if you're worried about a lot of things, it's hard to just let yourself be with your peers and to have fun with them. And then we'll also, of course, see anxiety and depression go together. So particularly for generalized anxiety disorder, social anxiety disorder, or social phobia are more likely to also have depression than, let's say, someone with a specific phobia, okay? In terms of gender, ethnicity, and culture, girls experience more anxiety disorders than boys, and that's across cultures and ethnicities. So you can see here from this graph, we see the blue line, which is the line down here. We see that, you know, not a whole lot of anxiety, and then this is age at onset, so 10, 20, 30. You know, not a whole lot. Look at what happens after the age of 10 for girls and women. Oof. We're anxious. We're more anxious. Now, there's always a little bit of a caveat there. Is it that males are anxious and don't admit it? Is it that males are anxious but turn to self-medication instead of turning to a psychologist? So we do see higher incidences of drug and alcohol use in men than in women, in adolescent boys than in adolescent girls. And so the question is that an attempt at self-medication instead of confronting the fact that they may be anxious? Don't know. Okay. All right, we are doing this. So some of the early theories and causes for the anxiety disorders as a whole, of course, classic psychoanalytic theory. It was thought that anxiety and phobias were defenses against unconscious conflicts rooted in childhood. Well, of course it was. What didn't Freud think was rooted in childhood and that wasn't an unconscious battle? Okay. From a behavioral learning standpoint, so behavioral and learning theories, fears and anxieties are thought to be learned through classical conditioning, and then operant conditioning explains the maintenance of fears. We can also learn by watching other people, so vicariously learning. So I'm walking down the street as a kid, and there's a dog in the yard at the corner, and the dog comes running over to the fence and snarls at me and is like yapping and yipping, and I'm like, whoa, it's okay, it's okay. And I put my hand out. I'm a young child, I don't know any better. I put my hand out and the dog bites my finger through the fence, right? Like if some of my finger goes in the fence, that's not a bad bite. I don't need stitches, I don't need anything, but I am now like, dogs are scary. So there's my pairing, right? It used to be that I would go for a walk, the house on the corner wasn't a threat, now there was a dog, now all of a sudden I'm scared of dogs. Well, I have a choice. When I go for a walk, do I walk by the house on the corner with the snarling mean dog, or do I go a different route? Well, I go a different route, right? So I start avoiding. And of course, the avoidance makes me feel better because I don't encounter the snarling dog. It also means that I don't know that they've moved away 2 months after this happened. And so for 17 years, I walked the long way when I could have gone the short way because there's no dog in the yard anymore. But I'm now also afraid of all dogs, all the time, okay? So that's behavioral and learning theories. It could also happen that if I saw my brother get bitten by the dog, I could be scared of dogs. He might not be, but I might be because I'm like, oh my goodness, a dog could bite me. That would be scary. That would be terrible. Okay, theory of attachment, which talks about it's good to be anxious when we're separated from our caregivers as infants, right? Because as infants, we rely on our caregivers for pretty much everything. We rely on them to change our diapers, we rely on them to feed us, we rely on them to soothe us, we rely on them to show us love and affection. And so when a caregiver goes away as a young infant, it's normal for us to express distress and to be bothered by that, and then to express relief when they come back to us, okay? And that's just strictly from a survival perspective. But the problems can develop if we're separated too early, if we're treated harshly, or if we fail to have our needs met consistently. So when we have parents who don't meet our needs all that consistently, that creates anxiety. We don't know, when I cry this time, will I get fed or will I be ignored? Should I cry? Should I not cry? Should I just start picking at the carpet and eating carpet lint? Like, I don't know. And if we're treated harshly, if sometimes, you know, I cry as an infant and mom comes and picks me up and soothes me and I feel better, but sometimes mom just yells at me, will you shut up already? And it's like, well, oh, I don't know. Or what if mom sometimes hits, right? Then should I cry? Should I not cry? How do I get my needs met? What do I do? And we can see how that would lead to some anxiety. Another factor that we have leading to potentially some anxiety is temperament. And we are all born with a temperament. We all sort of have our way of being. Some of us are easygoing, some of us are more tightly wound, some of us approach new things with fear and trepidation, some of us approach new things without a thought and we just jump right in, okay? And so people who exhibit behavioral inhibition or who have a more inhibited temperament, that may predispose them to anxiety disorders. So being a little bit slower, a little more cautious, a little more like, is this a threat? Should I be scared of this? Should I be doing this? We could see how that might work. So People with a behavioral inhibition may have a lower threshold for becoming overexcited and to withdrawing in response to arousal stimuli. Okay, so yeah, okay. In terms of family and genetic risk, children inherit general tendencies to be inhibited, tense, or fearful. We know that there's a genetic component. We know there's also a learning component, certainly, that we see in terms of family factors as well. From a neurobiological perspective, several systems are implicated: the HPA axis, the limbic system, particularly, again, that behavioral inhibition system, the ventrolateral and dorsolateral prefrontal cortex, and the neurotransmitter GABA, so gamma aminobutyric acid, is implicated as well. This, by the way, is the extent of how much you have to know the neurobiology stuff, okay? HPA axis, again, hypothalamus, pituitary, adrenal glands, that's responsible for our stress response. So, of course, that would be implicated in anxiety disorders. In terms of some family factors specifically, we know that anxiety runs in families. We know there's the genetic component. We also know there's the learned component. I thought it was really cool. I used to be a swim instructor and lifeguard, and when I was in university, I used to teach the parent and taught swim classes. Super fun, 9 o'clock on Sunday mornings. I had to be in the pool and happy, because you can't work with, babies and parents and be like a hungover misery. So anyway, and I remember this one family in particular, this always stood out to me. The child was somewhere around 18 months, so year and a half, 2, somewhere in there. And the mom always looked terrified. And one of the things we used to do in class, of course, was in terms of getting the kids familiar with the water, and parent and taught is really just about this, not about teaching survival swimming at that stage. It's let's have fun in the water and let's get used to getting splashed and dunking and being on our back and being on our front, right? Just to get comfortable. So she always looked terrified and she never dunked her child. And I asked her one day, I was like, are you okay? Like, what's going on? And she said, honestly, I am terrified of the water. I have always been terrified of the water, but I don't want my son to be terrified. So I push myself to come here every week with him because I want him to feel okay in the water. She's like, but there's no way I'm dunking, and so then I'm not going to dunk him without me dunking. And I was like, oh, well, I said, first of all, like, that's awesome. Like, good for you for addressing your fear and being really aware that you don't want your child to have the same fear. I was like, do you want me to dunk him? She's like, would you? I said, of course. So then I had my own little child model for dunking. So she would be in the water for the whole class, do everything except when it was time to dunk, she'd be like, here you go. And she'd pass her son over to me. And I would, look at him and we would dunk together. And then he'd be fine and I'd hand him back. So we know that he might have already had this genetic tendency towards being more anxious about the water. He might have also learned from watching his mom, but she was like, nope, I'm going to do this and I'm going to suck it up and do something that terrifies me in the hopes that you then won't be terrified as well. Parenting practices also play a role in anxiety. If they reject their kids, if they are too overprotective, if they're too controlling, if they model anxious behavior. So the ways we parent our children can contribute to them becoming anxious. Again, remember, parents aren't perfect. You're not expected to be perfect. You do the best you can with what you have. And then, of course, insecure attachment. So we've talked before in the semester about secure attachment and insecure attachment. And so children who have insecure attachment, so their needs aren't always consistently met, their caregiver doesn't always come back, they don't show relief when their caregiver comes back, are more likely to develop anxiety disorders. In terms of treatment and prevention, treatments are aimed at modifying 4 primary problems: the distorted information processing that we talked about, so how people are perceiving things that may not be threats as threats. Also, the physiological reactions to the perceived threat. So once you do perceive something as a threat, whether accurate or not, how do you react? Do you activate fight or flight? Or can you right away start counteracting that by maybe doing some deep breathing, something else to center you? We also want to tackle that sense of a lack of control. So people who are anxious feel like they don't have control over the situation. So we want to focus on what it means to have control, also what things we can control, what things we can't control. And then also we want to target those excessive escape and avoidance behaviors. So if someone is just trying to avoid the situation or escape from the situation, we certainly want to target that and teach other behaviors, right? So if we go back to that, the dog bit me at the house on the corner, which by the way did not happen, and I'm now avoiding that all the time, might be like, okay, what might be a different strategy? So instead of walking the long way all the time, what if at the house before the snarling dog, you cross the street, right? So you are getting yourself closer to the dog, but you're still not anywhere where the dog could actually hurt you, as opposed to going the other way and completely avoiding the situation. And then over time, we would be working towards getting the child to still walk right by the dog. Behavior therapy is going to be an important component in the treatment of anxiety disorders. Typically, we're going to do some sort of exposure therapy. What we can do are things like graded exposure, so it's gradual. So particularly with phobias, behavior therapy works really well with gradual exposure. So a child who is afraid of dogs, we might start with a picture of a cartoon dog, and then we might have a photograph of an actual dog, and then maybe a YouTube clip of a dog playing with a ball, and then a YouTube clip of a dog barking, right? Not snarling, just barking, and then a dog snarling, and then once we're getting more comfortable, an actual dog, and like work our way up to finally being exposed to an unpredictable, potentially snarly dog. We'll also sometimes do systematic desensitization, which uses that same graded exposure. We create that hierarchy of fear, and we pair that with relaxation exercises, so we become totally relaxed at the least fearful stimulus, and then we work on staying relaxed as we continue exposing ourselves to more and more fearful stimuli. Flooding is not something that I would typically recommend unless we were in a very time-limited situation, because here what we're doing is we're pairing the feared object with response prevention. This will have some application for obsessive-compulsive disorder, but again in a more intense setting. So somebody who has that, those obsessive thoughts about germs and dirt, a therapist might have them actually put their hand into a bucket of mud and not allow them to go wash their hand. So keeping their hand in the muddy bucket, talking about how they're feeling the mud getting under their fingernails and into all the crevices, and thinking about all the organisms that are in that mud, and the person sitting there going like, oh my, like why do I pay you for this, right? Like, why am I here? And they're like, I really want to go wash my hands. And the therapist's like, nope, not until you get comfortable. Okay, I'm comfortable. No, you're not. And so you have to sit there, and then they might say, okay, you can take your hand out of the mud. Oh, thank you. And they start heading to the sink, and they're like, nope, just kidding. You can't wash. Here's a dry towel. You can just scrape some off. And so again, you could get the sense of how anxiety provoking this would be. So we really don't want to use that, especially with young children, unless we really have to. We will also do things, especially with younger children, participant modeling and reinforced practice. So a child who's afraid of dogs, we might have them watch another same-age child interacting with a dog so they can see how to interact with a dog. It's one of those things that I certainly noticed when I had a dog. You could always tell which kids had dogs and which ones didn't. So kids would inevitably come up to me and be like, oh, can I pet your dog? And I'd be like, well, if she lets you, like, I'm not going to decide for her. And kids who were familiar with dogs would often approach her from the front and put out their hand first so she could smell their hand, and then pet her and it'd be fine. Kids who weren't familiar with pets would like run up from the side or the back to go pet her, and she would never let those kids pet her because she's like, what is this? Who's coming at me? Right? So we would have a child who's comfortable with dogs, model for the child who's afraid of dogs. Well, this is how you interact with a dog. So see, the dog is lying there. I'm going to approach it, but it's going to see me approaching. I'm going to let it smell my hand to get my scent. I'm going to keep my hand there until the dog seems relaxed and comfortable. How can you tell the dog is relaxed? Well, its ears are back, it puts its head back down, and then I'm going to pet it, but it's going to be able to see my hand going to pet it. And the child's like, oh, so dogs don't have to be scary, right? So they learn through watching someone else, and then we have them practice and, of course, reinforce all the good things that they're doing, the right things that they're doing. We'll also make use of relaxation exercises for something like generalized anxiety disorder. That can be very helpful because there are often a lot of somatic symptoms and those worries that just won't stop. So having something else that the child or adolescent can do that refocuses their attention and also helps them calm down that sympathetic nervous system can be quite helpful. And then we can also look at cognitive behavioral therapy, basically combining thinking with the behavioral techniques. So thinking more about why they're doing what they're doing and how, again, if I use the dog example, the dog isn't threatening, or if we're doing something like the hand in the mud bucket and talk about the fact that, what is actually in the mud and that some dirt is actually good for us. It helps us, it helps our immune systems develop antibodies and be stronger. Too much hand washing can actually be a bad thing and all that good stuff. So that's CBT. Apparently, we're heading into reflection question number 3. You've been waiting a long time for this one. Why do you think exposure is often part of treatment for both anxiety disorders and obsessive-compulsive disorders in children? Okay, so you've thought about this, and now let's come back and a little bit more on treatment and prevention. Obviously, family interventions. I've talked before about the fact that families often try to stay balanced, try to stay in homeostasis. So if you have a child who has a disorder, the family kind of balances around that. If you then have the child seeking treatment and things are getting better, that throws the family out of balance. So it's oftentimes important when we have a child as what's known as the identified patient that we also look at the whole family system and how the family system will accommodate the child no longer being symptomatic. We can also look at medication. This is going to be in really extreme cases. Again, we don't want to medicate children if we don't have to. And for some of these anxiety disorders, we will have a lot of success with behavioral interventions and we won't have to turn to medication, but we may have to, and that's okay. In some cases with obsessive-compulsive disorder, we need medication on board. With panic disorder, if an adolescent is having lots of panic attacks, we need to give them something to help them with that. And so we often will think about the SSRIs again, so our Prozac, Paxil, Zoloft, Luvox, Celexa, because these are medications taken daily that then help with the anxiety disorders in general. We might also, in a case like panic disorder where there are panic attacks happening, we might think about a short-acting medication as well, something like Xanax, which they could take in the moment. Again, we probably wouldn't be thinking Xanax as much with a child, more of an adolescent. And we may also use some medications that could help with sleep, depending on how bad things are. Again, those would be short-term. SSRIs would be the longer-term medication of choice if we have to go that route. And then we can also think a little bit about prevention. Prevention can be really tricky, but some interventions can start with children as young as 4. And I think a big piece of that is teaching children how to self-regulate is really important. Teaching children how to recognize when they are getting out of control, because that can also then set off that worry spiral. So teaching them how to stay calm, teaching them how to not necessarily meditate, but how to maybe do some breathing to help calm themselves down. And that can help have things not escalate into the stage of disorder.